Good morning. My name is Tiffany Ramsey, and today I'm going to be discussing temporal mandibular joint disorders, also known as TMD. So first, let's discuss what a TMJ disorder is. So the temporal mandibular disorder is just a group of conditions that affect the jaw muscles and the jaw joint. Some of the common symptoms include jaw pain and stiffness, limited movement or locking of the jaw, and a painful clicking and popping sound. So, although these symptoms can often improve on their own, there is a chance that it could become chronic and cause long-term discomfort to those affected. So, a brief anatomical overview. So, the TMJ is stabilized by several ligaments that limit extreme motion and awareness of jaw position. So, surrounded muscles of mastication, such as the masseter, temporalis, and the pterygoids, control the jaw opening and closing and the side-to-side movements. So functionally, the jaw opening begins with a rotation of the condyle followed by anterior translation along the articular eminence. So these movements allow for essential movements like chewing, speaking, swallowing, and facial expressions. They also contribute to middle ear pressure regulation. So some pathophysiological disorders that I found with the TMJ would be the mascatory muscle disorder. So common symptoms observed include pain in the mascatory muscles when swallowing, speaking, and chewing. This pain tends to increase with palpation or muscle manipulation. There's also the derangement of the condyle disc complex. So this arises due to the breakdown in the rotational function of the disc. This can result from the lengthening or thinning of the posterior disc in the jaw. There's also luxation. So dislocation happens when the condyle moves in front of the articular eminence and cannot descend back to the normal position. This can cause joint hyperextension, leaving the jaw in an open mouth position. So there are a few ways that have been used to observe TMJ disorders that allow for more accurate diagnosis. One being the cone beam computed tomography. So the CBCT provides a high resolution image of the hard tissue of the joint by providing cross-sectional imaging and three-dimensional reconstruction. So it is effective in detecting bony changes to show if there is osteoarthritis or degenerative joint disease present in the patient. There's also the MRI. So this has been the gold standard for assessing soft tissue issues. This imaging offers superior visualization of the relative position of the intravertebral disc and the condyle and its ability to detect joint effusion and inflammation. There's also ultrasonography. So this diagnostic imaging has gained widespread attention due to the accessibility, lack of radiation, and the ability to provide real-time imaging. This also allows the patient to open and close their mouth while observing the joint in question. So as for treatment, they do recommend reversible conservative treatment as the first line of trying to manage TMJ disorders. So these can include self-care techniques such as avoidance of oral provocations like daytime clenching, nail biting, and chewing gum. There's also the intraoral appliances. So by using a hard acrylic or a soft polyethylene mouth guard can provide full coverage of occlusal surfaces that can be worn at night, whether it's a upper or lower retainer. There's also pharmacotherapy, so taking muscle relaxants such as cyclobenzaprine can help alleviate pain. And also using NSAIDs, which is the nonsteroidal anti-inflammatory drugs, can help with the pain and inflammation. There are also some surgical treatments that can be done. There is the arthroscopy, which uses a camera to diagnose and repair specific issues with the joint, like tears or loose cartilage, while preserving the joint. And there's also arthroplasty, which replaces a damaged joint entirely, removing damaged cartilage and bone and replacing it with an artificial part. So one of the articles that I wanted to analyze and look a little further into was the Temporomandibular disorder, a review of current concepts in etiology, diagnosis, and management. This is my third referenced article in my referencing slide. So this article explains in detail that recent advances in the understandings of the etiology, pathophysiology, diagnosis, and treatment of TMD. It also expresses that TMD is not just a mechanical jaw problem, but a biophysiological, physiosocial, and multifactorial condition that involves the interaction between anatomical structures, neuromuscular function, inflammation, and genetics. It also addresses the anatomical issues by describing how dysfunction or pathology of the TMJ, articular disc, and mascatory muscles contribute to the pain and impaired jaw movements. So it mentions disc displacement, joint noises, and degenerative joint disease that do not correlate with pain severity, challenging earlier assumptions that structural abnormalities cause TMD. So despite having made several advances, there are still anatomical and mechanistic questions that remain unanswered. It is still unclear as to why similar anatomical findings, such as disc displacement, cause pain in some individuals and not others, and how structural TMJ changes interact with central pain sensitivity over time. Additionally, the precise role of joint inflammation, neuropeptides, and genetic variations in driving chronic TMD symptoms do require further investigation. So further research is needed to better link specific anatomical changes to pain mechanisms, which could provide diagnostic accuracy and treatment. So if there's any questions, any concerns, and this is my reference page. Again, the last slide was referencing that third reference. Thank you.